here. It's record. Yes, it's record. Thanks so much, Professor Jaap J, to take part of our medical minutes. Welcome. And as everybody knows, Professor Jaap is a reference on the study of diabetic foot ulcers in using thermography. And today he will present us about thermography to prevent diabetic foot ulcers. And we have the opportunity to know more about his researches, the expectation of future with this technology. And after his presentation, we will open for a discussion, questions, and to understand more. Thank you. Welcome, Professor Jaap van Netten, and feel free to present. And it's all your time now. Thanks so much, man.
Well, thanks so much, Professor Brioski, and I'm very honored, and you're way too kind in all these words. And yeah, I'm really honored to be here and to be able to talk. And I was asked to present in 15 minutes a little bit of background on what we are doing and how we are using tomography. And then I already have a disclaimer first. It's not a straightforward talk. Because tomography in the prevention of diabetic foot ulcers is not straightforward. So I hope that that you learn something, but I also hope that you get stimulated into realizing that we're not there yet. We're not at the end of the road here. We're in the middle, and we're trying to get these answers. And I'm happy to continue talking about that. And yeah, while I was working on this, I could have probably had 3 times as many slides, but I sort of tried to condense it to not overburden you straight away here. Let's get this started. So before some other disclosures before I start, but really anything that I'm doing could not have been done without all the co-authors. So really thanking any one of them. And for those who don't know, but I think it's good to be out there in the open. I'm the vice chair of the International Working Group on the Diabetic Foot. So when I say these guidelines are great, please be aware that it's just my own guidelines. So take that with a big pinch of salt. And I'm chairing the prevention working group, where we actually have a recommendation on how to use tomography to prevent diabetic foot ulcers. But obviously, yeah, that's my work. And our research could not be done without financial support, and the biggest funders are what you see down there below. A little bit of general background here in diabetes. Well, I don't think I have to explain what diabetes is, and I also don't have to explain that there's a huge global burden of diabetes. And what you're seeing here in this graph is work from Peter Lazzarini that I co-authored, where we looked in the Lancet Global Burden of Disease study. And so for those who don't know the Global Burden of Disease study, it's a huge, it's even bigger than that study by the Lancet, where they try of the 300 most common diseases, try to quantify what the burden is of that disease globally. And what you're seeing here on number 1, and then they express that in global disability adjusted life years. Let's not get into too much detail there, but on number 1 is ischemic heart disease, on 3 COPD, and on 8 you have type 2 diabetes. And so far nothing majorly unexpected. We all know the problems of heart and lung and diabetes. But what we then did, or actually what Pete Lazzarini did, he dove into that, and he found that within the diabetes group, you can separate the diabetic foot from other diabetic complications. And then diabetic foot disease in itself is the number 13 disease globally if you look at the burden that comes from this. And it's not unexpected if you realize that there's more than 100 million people at risk of the disease, that there is 20 million people annually with a foot ulcer, that there's millions of people with a lower extremity amputation every year, all as a result of diabetes. But it's a disease that often goes slightly unnoticed, that not many people like to talk about. It's your feet, it's slightly gross, it has these wounds that are smelly, we don't want to talk about, and sort of, it's not a sexy disease that you see all over the place, but it has a much bigger burden than breast cancer, then kidney disease, then dementia. It's really a problem where we should spend a lot more energy probably on in trying to prevent that. And one of the biggest challenges in prevention is what you're seeing here on this slide. So what they summarized here are all the studies, and we're talking about hundreds of patients, hundreds of thousands of patients in all these little dots. Looking at, okay, now you've had a foot ulcer, now you've healed, what happens then? And what we see is that within 1 year, 40% of people have already had a new foot ulcer. And we know that each foot ulcer increases the risk of amputation, and each amputation increases the risk of mortality, of all the other problems that come with that in the phase before. It reduces quality of life. And so what we're seeing here is that once you've had a foot ulcer, the chance that you'll have another one within 2 years are 50-50. Half of all the patients get a new foot ulcer within 2 years. And the only study that followed patients for 10 years, the one on the total top right, found that everybody had a new foot ulcer at least once in the next 10 years. So we know who the high-risk patients are, and we know that they probably get another problem. So we can do everything to prevent it. And what is then causing these foot ulcers to take place? And here you see a quite schematic graph of a typical foot ulcer, the graph that we put in the guidelines. But you see a toe that has a slight deformity, the result from neuropathy and diabetes. And then as a result of the neuropathy and simply of walking, you see callus forming and you see inflammation. And that's the key here for the thermography part. You see inflammation on this first part before the skin already starts to break down. We see a temperature increase, and then you get a hemorrhage, and then the ulcer breaks down and the skin breaks down and you get an infection. For those who like a slightly more extensive graph, this is work from Professor Armstrong, who was published in the New England Journal of Medicine, where they describe this in even more detail, how the various parts of neuropathy work together to create abundant callus, to get this inflammation that we hope can detect, and then leading to a foot ulcer. And for those who are more schematic, there are multiple pathways to foot ulceration. Some of the smaller one is vascular, more are mechanical, and the key part for the thermography part, at least, is the pathway that goes via repetitive moderate stress. And this is not stepping into a nail, because that's really high stress. That's the direct trauma that you see on the right hand of the mechanical pathway. This is repetitive moderate stress just from walking or standing. But if you do that with deformed feet that also are desensitive because of the neuropathy, that's when you don't feel when something's happening. You don't feel the blister forming, you don't feel the callus forming, but it happens in your body and the temperature is rising because you see the inflammation coming. At least that's the theory. And that's when, in the early 2000s, temperature monitoring already was taking place in this field. Because we thought that temperature monitoring, if you get inflammation before ulceration, and if you measure the inflammation, you can intervene before ulceration, and you can prevent the foot ulcer from happening. The first thermometer was the temp touch. That was the first one on this slide. And then many different ways of monitoring temperature in diabetic foot disease have come. Infrared, advanced infrared, or smartphone-based infrared. We get weighing scales, and we even have socks with thermometry included. But the disappointing point of view, at least from my personal perspective, from a scientific perspective, is that of all those devices, this is the only one that has been properly tested in an RCT design. So all the other devices are out there, but they do measure in different ways, and it has different interactions with patients, causing some of the questions we're still asking ourselves. But the big question we ask ourselves in the guideline perspective, and also here for this meeting today, is does temperature monitoring work in diabetic foot ulcer prevention? And why is it so important to ask yourself, especially in ulcer prevention, if something works? Well, prevention has this big paradox that we haven't been able to solve, because you have to do something for untangible benefits. So imagine that you are this person with diabetes, and your doctor tells you, yeah, you have a high risk of foot ulceration. Here is a thermometer. Measure yourself on a daily basis. You have to do it every morning on multiple spots on the foot. Write down what you do. And if you do it correctly, you won't get anything. So you've been doing that for weeks and weeks and weeks, and at some point you're just totally fed up because you've been doing it and you've never had tangible benefit, because what you have been doing prevented that foot ulcer from happening. And that is a huge paradox. That means that we have to have really good evidence to be able to ask our patients to do this on a daily basis. And now I realize that this is an American audience, I think primarily, but I've asked myself this based on the Robin question. So Arjen Robben is one of the biggest football players in the Netherlands. And when I go sort of to patients, it's similar. I always say also to our patients, we should ask ourselves the question, would a professional athlete do this? And what would they think about what you are presenting here? Would they be willing to do this on a daily basis? Well, if they wouldn't even be willing to do this, we can't ask this from you. And so Arjen Robben scored the winning goal in the Champions League final. So if this is the picture that you get, it means that he's pretty happy. He would think we should definitely do this. But a really sore point for me personally, I was there with 100,000 people on the big square in Amsterdam. He also missed this chance in the World Cup final in 2010. And so if you see this picture, you know that Arjen thinks we should not be doing this. And also, it's questionable. He doesn't really know. And so I'll try to use this in my talk. So what would Arjen think about the evidence that I will be presenting here? Well, the first thing in evidence, temperature monitoring works. We looked at 5 RCTs that have been done in the field, and the last one, BUS 2021, is the RCT that I was personally involved in as well. And we put all these 5 RCTs in a meta-analysis, and it works. All 5 RCTs use the temp touch that I presented earlier, asked patients to measure temperature on a daily basis on 6 spots on the foot, write down the temperatures, subtract them, look at the temperature differences. But if they did so, it has quite a big effect on ulcer prevention. A risk ratio of 0.51 means that we can prevent half of all the foot ulcers. So I asked Arjen, what do you think? And he was screaming. He said, like, yeah, definitely, we need to do this. But this is in trials. Trials are highly controlled situations where researchers spend a lot of time and energy with the patients. And actually, temperature monitoring works, but it doesn't work outside the RCTs. So far, there's only been one study, unfortunately only one, where people were given this weighing scale, much more advanced than the temp touch that was used in the RCT. And they had it for a year, and then they also measured the subsequent year. So 1 year with the weighing scale that measured temperature every morning, and 1 year without. And what they saw in the year that they had the weighing scale, 62 foot ulcers, in the year after, 55 foot ulcers. So does it have any benefit in those 2-year period? Well, obviously there's a lot of biases out there in the way you set up the study, but no, Arjen afraid thinks that this could be quite a miss, because if it doesn't change anything in the year afterwards, what did the monitoring actually do in this group of patients? And so let's look at it in more detail, because the people who designed this weighing scale also did an observational study earlier. And what they found in the observational study were some really positive findings. So they found that temperature monitoring had a sensitivity of 97% in actually being able to find the ulcer before it occurred. A specificity was much lower, and they said a lead time of 37 days. So what they found is that in the 37 days up to the moment of skin breakdown, because in this trial people were standing on the temperature monitoring mat without getting the feedback, so the feedback was only stored for scientific purposes, you could already see the increase in the foot quite early. But so that's the high sensitivity. All but one ulcer was actually detected in advance. But the low specificity means that there were a lot of patients where there was high temperature who never ulcerated. So it's not a perfect sign, temperature monitoring. And this is one of the pictures that they show. On the left-hand side, you see a patient who did not get a foot ulcer, so it stayed continuously low, the temperature difference. And what we're looking here is the difference between the left and the right foot. And on the right-hand side, you see a patient who ulcerated. And there, yeah, for sure, you can see that there is temperature increases in the period before the ulcer is there. But you also see that the temperature increases there actually quite early already. And that's one of the things that we wondered about then. What does it mean that you see a temperature increase that many weeks before the ulcer is there? Is that really related to the ulcer, or is it a chance finding? And that could be why in real life clinical practice it doesn't work, because, well, we may be measuring something but not necessarily the inflammation. We're just creating something to help people look at their feet. And then if you look at it more specifically, the negative predictive value is really high, but the positive predictive value, and that is what you would really like in a test like this, is actually really low. And that means that you will get patients warnings on numerous occasions when nothing is happening. And that would, well, imagine, again, asking Arjen Robben, that would be giving him the notion, well, you're at high risk of getting injured right now, you're not allowed to play the next match. Because that's what we're doing here. Because when people get a high temperature reading, we're saying to them, reduce your activity the next day. And so you're actually asking people to continuously reduce their activity and reduce what they do in their daily life and what they need to do. But most of the time, it's for nothing. And yeah, just imagine asking all your professional athletes that, well, we think there's an increased risk of you getting injured next match. Probably you won't be playing. But only in 17% of the matches would they have been really gotten an injury. So that's more than 80% of patients you're asking to do something where nothing would have happened if they would have just continued living their life. And that on a daily basis, year after year. So here Arjen feels like, nah, this could be a miss. But then came the even bigger confusing part in our own trial, because in our own trial, we could look at it in an even more detail because we had all the data and these were trials from others. So in the previous trial, we found that many people got a warning who did not ulcerate. In our trial, we found the opposite. We found that many people got an ulcer without getting a warning, and now we're totally confused. So what we found is 151 participants. We followed them for 18 months, and 29 of them developed a diabetic foot ulcer while they were measuring temperature. And of those 29, 8, around a quarter, had a true hotspot. So they really did what we expected to be happening. We saw an inflammation in the days preceding the ulceration. They didn't do anything. They didn't act upon their hotspot. But if they would have done, these are ulcers we could have prevented. But we also saw a quarter of the patients with false hotspots. So hotspot at completely different parts of their feet. And there we go like, well, yes, they had a hotspot. And in the previous study, they would have called that a positive finding. But this was not related to what was happening there. So this could be that they developed an ulcer on their hallux of their right foot, and whereas they measured a hotspot on the heel of the left foot, for example. So it's not a straightforward association between temperature increase and what's happening in the foot. And even more puzzling, we found half of our patients developing an ulcer without measuring a hotspot in the weeks preceding. So often the inflammation can't even be measured in the patient that we're looking at. So it still worked in the RCT because we still had a positive finding. But was it really because we measured the temperature increase? Well, in a quarter of the patients, yes. But why did it work in the other 3/4 of patients where we prevented the ulcer? And this is where the big question mark comes over. We really don't know. We have some ideas, but we do know that despite what we always expected, the skin does not always heat up before it breaks down. And it could be that the callus prevents the measuring. The measuring equipment wasn't sensitive enough to pick it up, or sometimes it just goes too quickly to pick it up if you measure on a daily basis. What could be the case here is that in those RCTs, the device actually acted as a surrogate, because we asked people to measure temperature on a daily basis. But when you measure temperature, you have to look at your feet. And looking at your foot on a daily basis is an important self-care recommendation for people with diabetes. And it's something that's often hard to do. But when you do it with a cool gadget that gives you numbers and gives you a beep and tells you something, maybe people are actually more willing to look at their feet. So it's not necessarily the temperature monitoring, but the fact that you get a gadget to do it. And the gadget gives you numbers and helps you work in there. In a quarter of the patient, yes, because that's still the patient where you did see the inflammation. But with the others, it could have been the surrogate, it could have been something else. Or, and that could be the other part of the explanation, it only worked in some patients, and that's enough to create a significant effect. And it's enough to warrant it as a useful preventative device. But we have to be cautious not giving everybody this and asking the millions and millions of people who are at high risk of foot ulceration to do this on a daily basis, because that's overburdening patients who are already burdened by the disease and by what's happening there. And so summing this all up, it's a big win. This is also a big loss, and at some point we don't really know. But obviously that's not how a guideline works. So this is how a scientist works. The scientist goes like, well, some of the evidence is very positive, some of the evidence is quite negative, and some of the evidence we still haven't got the answer. But we're writing a guideline for clinicians, and in the guideline, in the end, you have to stick your neck out and you have to come to a conclusion. And that's how I'm ending up this talk here, because if we consider all the evidence are out there and all the knowledge that we have on temperature monitoring and also prevention, this is what we think is needed, is that you should consider coaching a person with diabetes who is at moderate or high risk of foot ulceration, and we stratify that as International Working Group on Diabetic Foot risk 2 or 3, to self-monitor foot skin temperatures once per day to identify any early signs of foot inflammation and help prevent a first or recurrent plantar foot ulcer. So yes, if you do sum it all up, it's a conditional recommendation. We think this should not be done for every single patient out there, but it could definitely be a part of this treatment, the treatment armamentarium that you have as a podiatrist or as a clinician trying to prevent ulcer, where self-monitoring foot skin temperature may help to prevent foot ulcers. But it's about how you apply this in your daily clinical practice that then helps you to make the best use of this strategy. But this is where we came up in the end, sort of balancing all the evidence on temperature monitoring and also prevention. Do it, but do it cautiously and carefully. And with that, I'd like to thank you all for the attention.
Congratulations, Jaap. I like so much. You summarized the literature and more recent point of view of that. And I believe we have many questions. I'm open to the people to do the question. I know some people want to make a question. At the end, I comment my point of view. Please, anyone will have a question? Cidalia, no.
Talk. Sorry, I have no voice, but it was magnificent. I understood that it's important to monitor the temperature of the feet every day. And I was thinking that maybe because of this self-attention, it's probably help for each individuals to take care more about their feet. And probably it can be a conscious good condition to help them to prevent also the lesions, the trauma in their feet. And I don't know if we can change the results of this research that we're doing, because once people knows that they need to take care about the health of their feet, and every day they are going to measure the temperature. For my way of thinking, it says that, well, I have feet that is on risk, so I have to take care more about this. And I don't know if this can be a bias in a study, for example, because it's the self condition of the individuals. Okay, can you understand what I'm saying?
I think you're totally right, and actually I think it's part of the treatment effect of temperature monitoring is that you increase the awareness. But that's important to realize, because one of the newest strategies that we were seeing, for example, with the weighing scale or with the socks that you put on, is actually taking away that, because the machine is doing it for you. You just stand on the weighing scale while you brush your teeth, and you don't look at your feet, or just pull on the socks and the sock is doing the work for you, but you don't look at your feet anymore. So if we truly believe that the thermometry and all the trials use the same temperature, where you have to look at your feet as well. If part of the effect is the fact that you look at your foot, then we should make sure that the next temperature monitoring device that we're making, that is making it easier for patients as well, still requires them to look at their feet. And what we're doing now in our trials, so this was the closed trial. We're in a current trial where we're still implementing temperature monitoring. But what we're doing there is that we're not asking patients anymore to do it every day of their life, because our first trial is 1.5 years, and that's a really long time for patients to do something on a daily basis. But now, the first 2 weeks, they do it on a daily basis, and then we discuss with them, how would you like to do it? Would you like to do it every day? Would you like to do it only once a week? And we really give the choice with the patient. And against our expectations, we found that many patients said, like, I'd like to continue doing it. But it really felt like their choice, rather than us as researchers or doctors telling them, this is what you need to do. And so by making it their choice, they're actually doing it more often than we expected. And some of them, no, they're only doing it once a week, or they're only doing it after they've had a big day out where they've been really active and just to see, oh, is everything all right? And they have it as a sort of backup tool. And I think that's well, we haven't seen the data yet. We were only in the middle of the trial, but it definitely from the feedback I get from patients feels like the best way of sort of getting the most out of both. You get the measurements on a frequent basis. You get patients to look at their feet, but you're not overburdening by making it mandatory that they look at it on a daily basis.
Okay, thank you.
Great.
I also was thinking if you had compared the temperature with the symptom like pain and also with the glucose levels, because we can have this comparison and say, okay, if you have a high glucose level and feel that you have pain in your foot, you probably has higher temperature. Have you compared any time about this field?
No, we haven't. But you're totally right. I mean, well, most patients in our trials have painless neuropathy, so they don't have pain, and actually they feel nothing in the feet anymore, which is a bigger problem than feeling pain for some patients. But yeah, we did wonder about it. But what the problem with temperature monitoring in the foot is often that it is relatively unstable, as in the sense that foot temperature is quite heavily influenced by what you've been doing before, what the surrounding temperature is doing, and so many different determinants play a role there. But that's why we always compare the left and the right foot, because with almost all of them, the left and the right foot have had more or less the same. And then the temperature difference between the left and the right foot is really what we are using, but that is a purely a local process. So that obviously won't tell you anything about high blood glucose or anything else, because that's a full body process. But for the local processes, left versus right is really a useful
Okay.
comparison.
Okay.
Yes, as you
I'm
told
loving.
before, it's not easy to
Yeah.
study this because we have so many other influences. For example, if you have a
Excuse
patient,
me.
a diabetic patient that has one leg uh, smaller than the other one, so the biomechanic will take more heavy, more
Overload.
in one leg than the other. So when he's walking, you have the
Overload.
yes, the load in one leg, so it can interfere also. Thank you very much. It's not an easy subject. It's not an easy thing to do, but you are bringing
I
us a
I
new
love
future.
in this
Thank you very much.
discussion. I love in this discussion, and I want to inform that we have many questions. So I will ask for I will call for everyone do the question, but do very short and try to be objective because we don't have so much time, and I expect that Jeff can help us with the questions, and also Jeff, if you can short your answers go. Okay,
I'll do,
you're
I'll
okay,
do my
but we
best.
don't have so much time, and I believe we have many good questions here. So I open first for Meshara. Welcome. Please go ahead then.
Thank you. It's good to see many familiar faces. Great presentation. I'm wondering about the use of thermography, not for monitoring, but for screening. Just like patients with diabetes do neuropathy screening or retinopathy screening, can we use thermography? We've just done that with 1,000 patients in 3 weeks. I'm curious to hear your thoughts.
Oh, it's well, the thing with tomography is that what we know so far is that the relation to ulcer risk is quite temporarily. So if it's high, you can get it back to normal. And in any of my studies, we haven't seen anything in foot thermometry that is a reliable predictor. People with lower temperatures who never get a problem, people with higher temperatures who never get a problem, people with in between. So I often see that this too much happening, but then again, I fully agree. I would love to see the data from the 1,000 patients and then follow them over time, because there hasn't been enough studies there to really sort of show that it's not an effect.
We got 10% out of 1,000 at high risk, but I'll gladly share it after.
Sergio, go ahead. you mute, please.
Okay, thanks so much. Congratulations, Van Netten, from your researching. My question is, from the patterns follow-up from these patients around neuropathic thermal signatures, you analyze and compare for vascular pattern signatures, and this relationship about brain thermal tuner. Are you experienced about that? You analyze it anymore? Thanks so much. You understand?
Sorry, you mean if we looked at patterns that differ between people with neuropathy or people with PAD?
Yes.
Yeah, so we've looked at that, and severe ischemia, and I saw a comment from Jan in the chat that cold can also be a problem, and severe ischemia is something that you can identify with the foot being much colder than expected. But again, it's the left-right difference that gives away that something is happening here. And in that case, sort of, it was a sudden much lower temperature on the foot that led the patient to come in, and we found the ischemia. So yeah, it's playing a role, and the neuropathy is obviously causing problems in the foot, but often it's doing it left and right the same, and that's why we're always interested in the difference between left and right. But if you would patients follow over a much longer time when they haven't had neuropathy and then see them develop neuropathy, then it could for sure play a role.
Thank you.
Okay, thanks.
Katie, please.
Hi, thank you. Thank you so much for the presentation. It's great to see the information just portrayed in that way. My question is involving analysis. Is the analysis based solely upon delta T parameters, differences from right to left, and specific patterns, or is it always correlative to a physical deformity, visual evidence of a concern, or is it a combination of both?
Now, when in the patient's home, it's purely the delta T from the left and right foot on the same spot. And that's because for patients, it's much too complicated to do something else. Mm-hmm. From a research perspective, we've looked at different patterns, but we just haven't found convincing evidence telling us what we should be seeing in the patterns. And that could be because we're either asking the wrong questions or we just don't have the high quality data there. Whereas the delta T keeps it very easy for patients and understandable, and I think that's where we are right now. But now we should definitely be looking at the patterns for sure. I just don't have the data.
Yeah. And is there a delta T threshold that you've established at this point, or is it just any delta T?
No, so the threshold is 2.2 degrees Celsius or 4 degrees Fahrenheit. And that's when, and if that difference stays for 2 days in a row, that's when they need to call the physician.
Yeah. Great. Thank you.
Javier, please.
Thank you, Marcos. Great talk, Jaap. I enjoyed it a lot. Yeah, I know, well, Arjen Robben from the matches because of that penalty kick against Mexico, which was kind of well. I bet there's suspicious about if that was a fall or no, but great player. And my question is, I have done a lot of thermal simulations of the feet, and I think a way to understand better the results you're getting is to make like a thermal simulation of the feet, and you can put like the callus on the feet and see how the temperature pattern changes. So that way you can know ahead of making the temperature measurements what are you going to expect. So I mean, when you have a callus, the conduction of heat from the core body to the surface of the skin is going to change, and you can see a very distinct signature. So you can tell, okay, this is a callus, and this can be a problem. Or if it's an open wound, you can also simulate that, and that would give you a better understanding of what's going on with the temperature measurements. Because sometimes, I mean, most of the work that is done is more empirical, that you say, okay, I have this temperature pattern, and the clinical findings are this, so you try to match clinical findings to the temperature patterns. But if you have like a simulation, you can change the parameters and see and expect something from your measurement. So that's something I've been doing for quite some time, and I think that's something that can help you in your research.
Yeah, that's great to hear, and I really think that there is so much we can visualize with temperature that right now sort of remains a little bit something we can't really grasp or we can't visualize. And I've done a bit of studies with the infrared imaging, and patients really like those type of images, and sort of it really brings out something. And there, yeah, you can see the ulcers when they're there, and sort of how they shape. You can see the colors every now and then. But yeah, I just don't have the proof yet. But really good to hear that you're working on that. And yeah, we just need all that published and get that evidence together.
Thank you. Jen, do you want to open your microphone and do the question?
Yes, I did. Thank you. Can you hear me?
Yes.
My question, I did place in the chat. We've had some good experience with looking at diabetic circulation with both near infrared, which determines oxygenation, and then overall far infrared to look at the circulation changes from the knee to the toes. This image, just like the previous speaker mentioned, demonstrates visual changes in the circulation to the regions, and contact temperature measurements do not correlate because we are looking at overall circulation versus just a contact temperature that can be very variable.
Yeah, there's so much more possible. I agree. I don't have the experience here myself. What we did do, and where we did run into problems in people with diabetes, is that we tried to use hyperspectral imaging to visualize oxygenation. But what you see in people with diabetes is AV shunting. So from the arterial to the venous system, there are shunts going, and actually what we then saw is higher oxygenation levels, which we thought are really good, but actually those turned out to be the oxygenation levels in the venous system, which is why you don't want them to be high, which meant that the oxygen wasn't actually reaching the tissues. And because there's quite a lot at play in the foot, often we're struggling with being able to truly analyze what we're seeing. But I completely agree with you that there's much more possible than what we're doing right now and we're having in our clinic right now.
I was involved previously with a study at Duke University where we were looking at evaluation of overall pressure ulcers for this was pre-admission damage to the skin, so that in the United States we have financial implications if patients come in with pressure ulcers and we have not identified them. So we were using far infrared to image all bony prominence areas so that we could identify if there was a change in circulation related to any of these places, and they would be indicated on the admission so that the penalties would not be incurred. That study went through 2 phases. It did not make it to the 3rd phase, obviously, because of funding, as well as I do. Funding in this type of research is challenging. However, we did get some excellent information. That study was in the mid-2000s. But I so appreciate all of the information that you provided to us. I think that in our clinic settings, we can do much more for these patients by utilizing all the new tools that are available. Thank you. Thanks,
I fully agree.
Thank you, Jen. Now I will do my questions. We have 20 minutes. I believe I have 3 or 4 questions here. I took note of some points, what you put on your PowerPoint, and it was very good, and you summarize and update us. So the first question is, we know thermography has a high sensitivity, but as you show, look like low specificity, and that nearly half of ulcers develop without any prior thermal abnormality, especially visually. We can't see this. And how can we rely on thermography as a primary screening tool if it fails in literature to detect 38% of cases? Given this limitation, what other diagnostic methods should be combined with thermography to improve accuracy, in your opinion?
Yeah, I think that's the key. We cannot rely on it as the primary diagnostic tool, but that is what we're doing right now. Is we're treating each ulcer as the same, but all ulcers are different. We're also not treating each cancer as the same. We have all these differences for cancer depending on where on your body the cancer develops. And I think for an ulcer on the foot, we have to look at like that. An ulcer on the metatarsal head is different from an ulcer on the dorsal side, is different from an ulcer on the hallux, is different from an ulcer on the medial or lateral side. And so we should be narrowing that down, but that requires many more patients, which we haven't had in our trials. And the other thing is, if for diagnosis, it's in the end still a clinical diagnosis. So you require patients to look at the foot in addition to tomography. I think those would be the key that we have available right now. And then the others is, yeah, if we can create more advanced technology in addition to temperature. I still think temperature is a really useful tool to have, but you need a toolbox.
In your presentation, you suggest that increased temperature may not be a direct marker of ulcer formation, as I understood. Does this mean thermography is simply acting as a surrogate for another physiological process we don't fully understand, or would it be more effective to develop a multimodal algorithm combine temperature with other risk factors like plantar pressure, as Cidalia tried to explain, and microvascular circulation, and some new and develop an AI approach as similar to mesh, similar to Mesh-RAI is doing.
Oh no, yeah, absolutely right. As in, temperature is part of the equation, and pressure plays a role. But what you're seeing, if you're seeing 2 days in a row a high temperature, if a patient acts on that, then the temperature will reduce and the inflammation will reduce before the skin breaks down. And so it was still a sign of increased inflammation, but inflammation does not always have to lead to skin breakdown. And if behavior changes, then you were there on time. And so thermometry can still be a signal that something is happening in the body, because I always think that if you have at one spot a higher temperature than at the other spot of the same or the same spot on the other foot, then something is happening. But that something is not always skin breakdown, but it could be a pre-stage. But if you act upon it, if you start wearing your shoes, or if you are less active the next day, or if you go to your podiatrist, then you've been on time. So it's, yeah, again, it's part of a toolbox, but you also need to look at all the different factors at play there.
I did the opportunity to do this question, the next question I do, for Professor Armstrong, and he replied something, and I want to now to compare with you. And my question was, if you randomized controlled trials and show thermography is effective, why has it not been widely adopted in clinical practice? And what would it take for thermography to be integrated in global diabetic foot prevention protocols, such as those from the ADA and IDSA, the international protocols? What's your opinion about that?
Yeah, a great question, and it's So the temperature was created by a company, and that company went broke despite having 5 RCTs showing that your product works. So I'm still puzzled by it. And I think this is really the prevention paradox, that you have to invest before you get a reward. You have to invest now in giving patients a temperature monitoring device, whether it's a temperature or something else. And then the benefits will be that that patient doesn't get sick. But nobody is feeling the benefits. The benefits are not tangible. The system is not seeing that they prevented 10,000 euros or dollars in your case from being spent on the ulcer that didn't there, or $50,000 on the amputation that didn't take place. So nobody is feeling the benefits, whereas everybody's feeling the pain that you have to pay in advance. And I think that is the big challenge here, is that, yeah, we just don't have our systems in place to properly reward prevention. We're a punish-based system. So I think that the economic case is somehow not strong enough that people are really willing to invest in prevention, which is stopping companies from really going into the field. And it is slightly changing. We now see a bit more companies, especially in the US market, really getting into it. But it's taken 2 decades to get there, even though it's been in the guidelines for a decade already. So I think it's primarily money that drives this lack of implementation. And secondary, we don't have the systems ready for all the podiatrists to hand out this to our patients and then act upon it.
Yeah, when I discussed with Professor Armstrong, we discussed about the difference between home monitoring, temperature, and clinical monitoring with infrared imaging, for example. Mm-hmm. And I believe it's totally different. And we have good results for home monitoring, but not yet for infrared imaging based on clinics. And other point is that we need to reinforce in all the papers the importance in public health, to show that, oh, it's very important public health, to show then the numbers, the costs, or how much we can reduce the cost. And I believe this will the points that we need to do in the future. And I had the opportunity here in Brazil to take this a similar presentation as with the numbers that you presented to the health ministers here, and they say, oh, interesting, just this interesting, but okay, but and then with so people see it's good, but they don't understand how to implement this. And one point that I don't believe it works so good for home monitoring, in my opinion, is that when the doctors pass responsibility to monitoring to the patient, we have here kind of legal problem, because we never knows if the patient is really measuring right temperature, and we passing him the responsibility of his ulcers, and this could be a little danger or a little confusing to them. So I believe we are not on this step yet to pass the responsibility to them, but we can make it focus more on doing the follow-up of these patients with thermal imaging or monitoring them on the clinics, instead to give them on this moment the responsibility. We know it works, but we know it's not full accepted yet, and maybe we can adjust this in the future doing the monitoring on clinics. Do you agree with this opinion? What do you think about?
Well, for monitoring the clinic, the big challenge is that for the current thresholds are that you need to repeat it on the next day to confirm that the temperature is high, and the clinic is a one-off, and you often don't see your patients back. But you have the advantage that you can have much more advanced systems, more expensive systems, and that you have the control. And it's about finding the balance. I definitely think that some patients are really capable of temperature monitoring, and we should have by now the systems and the cheap thermometers to give out to these patients, but yet we still don't have it. And yeah, that is disappointing, but I think that's just because prevention is so hard to see, and we are afraid to give it to our patients, and we are afraid of the consequences that, not a thermometer does not pick up all ulcers. You won't prevent all ulcers, and so patients will get disappointed with it. So it's really about all these interactions at play here. And what you're suggesting, having it in the clinic will be a step, and then you learn what are the patients that probably understand it, what are the patients that might be able to use this. But yeah, we should really try and get it out there.
Your last slide, in my opinion, was the most important because it shows the international world guidelines, and everybody here must know that we have international guidelines that recommend thermal monitoring, but the question is only for moderate to high risk patients there. But it's good, but only. Does this suggest thermography should not be used universally, but either in specific subgroups? So maybe we could turn this better. If thermography is not universal method, what criteria should be used to determine which patients should undergo thermal screening?
Right now, the easiest is if you have a patient who has a foot ulcer, and then the moment that ulcer is healed, that's when you need to go to temperature screening, and then follow it in the first 3 months, because the biggest frequency of recurrence is in the first year after healing. So if there is ever a year where you really want to sort of focus in that patient, when they come in with the foot ulcer, start with doing it. When the ulcer is healed, do it, and then repeat it in those first weeks, because the longer you keep a patient ulcer free, the smaller the risk that a new ulcer will develop. So if you would start anywhere, start in the patients who have just healed from an ulcer. That's where the biggest change can be made.
Do you see a future where AI can detect complex thermal patterns alone?
Yeah, for sure. I mean, if you have, but the thing with AI is you need AI is just a statistical method looking at the probability of something happening. So you need reliable data to train the AI. But if you have reliable data that where you really know what you're seeing in the temperature, and then you can train the AI, and then you can feed it. Yes, because temperature is a very quantitative solution. So if you've properly trained it, yeah, definitely.
And if data shows thermography can reduce hospitalization, amputations, why is it still not widely covered by health insurance? And would the large-scale cost-effectiveness studies help convince government insurers, in your opinion? How should design?
We did a cost effectiveness study, and we showed that it is highly cost effective. And we went to the health insurance companies, and they said like, yeah, good for you, and then they moved on to the next. So it was quite disappointing. Sort of, I thought like, now I have the data, now I show it to you, and here you will come and say like, okay, you're right, now we will start to pay for it, but still they won't. So yes, data definitely helps, but it just requires everybody to keep banging on those doors and tell the health insurance companies this works. If you invest $1 here, you will save $100 there. But all they see is I have to pay $1.
And Netten, what do you think about to design a multi-center study? Because, for example, here we have many. Everybody here has an infrared camera, works in a clinic, see many patients. Most of them have diabetes. So I believe we could do a multi-center study or try something to reinforce this aspect in different countries at the same time, during the same period, and doing the same protocol, and could be very interesting. United States, Europe, South America, Asia. We could bring some news to this and change the history. And maybe with your help or your experience, could be very interesting.
That would be absolutely great. Yeah.
The last question, if you had unlimited funding for research in this field, what would be the next major breakthrough you would want to see? For my last question here.
What I would really like is to create an imaging device that not only measures temperature but also skin quality. And because that's the thing, I think we know definitely not enough about sort of the flexibility of the skin, because that in the end determines skin breakdown, and then also add blood flow, and sort of to have really this tool where you can image the entire foot and tells you this is the quality of the foot, of the bony structures in the foot, of the skin, of all the soft tissue. If I had unlimited fitting, that's what I would like to make, and then create it in a way that you can, with your own iPhone, scan 3D your foot and just have that image and tells you this is the quality of my foot, and then sort of follow that on a daily basis and really intervene before something is happening. But yeah, I would, if we could visualize all that in a quantifiable way, that would really be awesome.
Thank you, Professor Netten. We love your presentation. We are more inspired now. Let's keep in touch. Let's try to see if we can design some paper on future studies together. And the last 5 minutes here is to thank everybody to take part of our medical minutes, and say if you have any training outside US in a recognized institution like São Paulo University or a Brazilian Society, Uruguay Association, or some European society, the American Academy is giving a certificate of recognition for outside trainings to incentivize people to be together in our institution. You just need to be a member and be active and take part of our meetings like this one, and spread the words for more people to know the benefits of infrared imaging, thermography, thermology, to have a better life. Thanks so much for everybody. Thanks so much, Professor Netten. Nice to meet you, and see everybody to the next medical meeting. Good Saturday. Bye-bye.
Thank you.
Thanks so
Bye-bye.
much, everybody.